stage for the state-of-the-art lecture today, Mike Vaezi from Vanderbilt. And I want to note that he was introduced as a professor of medicine, but he's actually also a professor of ENT. So I think that may play a little bit into what he's going to tell us about next. Michael, you're very welcome.
Great. Thank you so much. Great. Thank you. Yes, I got an honorary degree of otolaryngology, and the way that came about was I paid a few people off, and I said, you know, part of what I'm going to talk about is reflux, this overlap with dyspepsia, obviously. We're going to go through some definitions, but looking outside the box on some of the extra esophageal patients that we see with globus, sore throat, and maybe including them in this, what I call a Rome 5 criteria maybe. So I'm going to be a bit provocative on maybe including them in there. But really getting to what we started to talk about with the abstracts on patients that don't improve, and looking at potentially what the possibilities may be and how best to, and what to tell the patients. At the end of the day, this needs to be a practical approach as opposed to research approach. I'm a bit sensitive about that because in research arena, we do a lot of stuff that may or may not translate to clinical practice. It might improve the needle as far as pathophysiology, but did it help how we manage the patient? At the end of the day, that connection must exist. So, let's talk about why patients don't get better. All right, dyspepsia. The definition is essentially a constellation of chronic upper GI symptoms. We got indigestion, discomfort or pain, early satiation, fullness, bloating and burping, nausea and vomiting. Common complaint, up to 30% prevalence, normal life expectancy, and the large cost mainly due to either diagnostic therapies or suboptimal therapeutic options that we currently have. The underlying cause for dyspepsia, well, reflux, obviously. That's an easy one because that's how we treat patients and the ones you see there. And then at the end, when we rule all of these out with the diagnostic tests that I'll discuss, we end up with this functional dyspepsia category that we don't really know a whole lot what to do other than some of the neuromodulative therapies. So this was Rome 3. You had bothersome postprandial fullness, early satiation, epigastric pain, epigastric burning, and then with Rome 4, we had the PDS and the EPS, epigastric pain syndrome, and obviously you have to have no evidence of structural disease, symptoms present for at least 3 months, onset at least 6 months before the diagnosis. What is postprandial distress syndrome? Must include one or both of the following: bothersome fullness, postprandial fullness, for at least 3 days a week, early satiation that prevents finishing a regular meal at least 3 times a week. And then some of the supporting criteria that you see there. Epigastric pain must include at least one of the following once a week: bothersome pain and or epigastric burning with supportive criteria. So essentially we're talking about dyspepsia and functional. This is the pathophysiology of functional disease. Again, very important to understand that there are multiple causes for this: psychosocial, altered brain-gut axis, genetic, delayed gastric emptying, as was discussed earlier, visceral hypersensitivity, and altered accommodation. And then we talk about reflux. Remember, reflux is common. Someone comes to you, you got heartburn, you put someone on a PPI, they get better, they don't get better, you alter, you up the dose to twice a day, as we talked about earlier. These are the esophageal syndromes. Anytime you do endoscopy or any of the tests and you find significant abnormal findings, i.e. grade C and D esophagitis, large hiatal hernia, patient has heartburn regurgitation, you're going to feel a lot better with your diagnosis. Then, patient has heartburn, they're having it daily, it is postprandial, you do endoscopy, it's normal, you do pH monitoring, well, it's barely abnormal. And the patient has not responded to twice daily therapy. So, what do you do with that finding? Well, you start saying things aren't fitting. So the key becomes, all the diagnostic tests that we do are designed to alter the pretest probability of our clinical suspicion. So I think that's how we should look at it. As opposed to a test telling us what it is, a test is really only helping us come up with, did that move the needle on our clinical pretest probability? I come to you with dysphagia, and I've had food impactions, and I'm 30 years old. You already have a probability in mind. Then you do your endoscopy, and that adds to that probability based on your endoscopic finding. The way we should look at all of our diagnostic tests is really not, did it diagnose? Did it really help us with our clinical suspicion? Where we fall astray is when we know what it could be, but then our diagnostic tests tell us something that strays us, and we go, oh, well, now I'm confused. I don't know what to do. Well, the reason you're confused is you feel as if somehow that diagnostic test is it. Anything I talk about this morning, consider it as only add-on to what you suspect. Your clinical intuition is always going to be better than any test that you're going to have. And we can have a discussion on that. So let's talk about it. Refractory GERD. Please don't say someone has refractory GERD, because if it's refractory GERD, by default you're presuming they have reflux, and it's refractory. So the reflux is a presumed diagnosis. You've diagnosed the patient. Refractory symptoms says patient has a symptom that is not better on PPI therapy. That has a different implication. So refractory GERD, what does it mean? It means someone has a symptom that's been treated. PPIs, H2 receptors, prokinetics, alginates, they're not better. And then that leads to all these tests and referrals that we know about. When you look at estimated cost of treating reflux, $12 billion. And then you add on the extra esophageal patients. These are patients with sore throat, fullness in the throat, laryngitis, if you will, from your ENT colleagues, chronic cough patients, and asthma patients that may be referred to you because could reflux still be causing some of the asthma issues. That adds a lot of money, $58 billion, almost treating our cancer patients. When we did this study on the cost, we thought maybe the cost of extra esophageal care may be because of our diagnostic test. Our pulmonary doctors do bronchoscopy, we do endoscopy, we do pH monitoring, we do all of these other tests. But that's not the driver of this. The driver of cost is unnecessary PPI therapy for too long. So the number one message in this would be not to treat someone chronically with PPI unless they need it. How do you know they need it? In the era of empiric therapy, you tried it, patients actually improved. Then you taper to the lowest dose of your PPI or H2 receptor antagonist or whatever it is that keeps them asymptomatic. So don't leave someone on BID dosing. They're not better, and just leave them on that. If they're not better, taper off. If they are better, taper them as low as it can go. Remembering that 50% of your patients that truly have reflux will still need once-a-day PPI therapy because they can't go lower than that. But you won't know who that 50% would be until you taper everybody. And I'm not saying any of this because of all the side effects that you're reading about with PPIs. It has nothing to do with that. We can discuss that if you have questions on it, because I think those are associations, not a causal link. We can discuss it, but the driver of this is unnecessary therapy for many of our patients, so we have to be thoughtful. So we can discuss later. All right, refractory GERD, I already said please don't use that term. Just use refractory symptom, because a patient with burping is not GERD. A patient with epigastric discomfort postprandially doesn't necessarily make it a GERD diagnosis. We're using symptom for a presumptive diagnosis, then we use treatment that becomes chronic. That's a problem. We have patients that are admitted to the hospital, they're not on PPI therapies, they leave on PPI therapies. We have to be very thoughtful. We talk about this with our residents and fellows. What was the indication for the PPI? Admission to the hospital cannot make it an indication, right? But that's what it's become. So be thoughtful, especially with this treatment. So the current diagnosis, or at least the way we use diagnostic testing, is we treat someone with once a day, they're not better or suboptimally improved, then you go to the off-label dosing of BID, then if they're not better, we do the tests. In the 1980s, it was different. We used to do the diagnostic tests first, then we would treat. 1990, when our first PPI came about, omeprazole came on the market in 1991, well, at that time, we were also doing the diagnostic testing early because we were worried PPIs would cause stomach cancer, right? Carcinoid syndrome. So we were only using it for 2, 3, 4 weeks at it. That was it. Now we got PPIs and everything. We give PPIs and then they've been on it a year, they're not better, we still think it's reflux, and then we do the tests that I'm gonna talk about. PPI trial, if it's extraesophageal, the current recommendation is you start with BID dosing, then taper down. The reason for that, if you're using PPIs as empiric, BID dosing essentially eliminates the acid in the esophagus in 98% of your patients. So if you want to use it as a diagnostic test, you want to use it so that you know acid is not continuing to cause the symptom. If the patient continues to be symptomatic, the one answer you know is it's not going to be acid. It could be non-acid, it could be regurgitation, but it's not acid as the cause of the symptom. PPI once a day for most others, and then taper to H2s or to lifestyle. Just a few words on lifestyle modification. Please don't hand this piece of paper to your patients of don't, or do, because they won't do don'ts and do's. So what you want to give them, tailor it to them. So drinking a glass of wine is associated with reflux symptom, but not because it induces reflux. Coffee is associated with reflux, but not because it induces reflux. It is reflux. They're all acidic, right? Soda is acidic, wine is acidic, coffee is acidic, orange juice is acidic. It isn't that you swallow something, goes in, produces gastric acid, which then refluxes. You have a patient that has reflux. It sensitizes the esophagus. Now you drink something that's acidic, and guess what? You feel it. So if you have a patient that after drinking a cup of coffee has reflux symptom, you tell them don't drink the cup of coffee. If one cup doesn't do it, the second does, you drink a cup, not the second cup. Now, as simple as it sounds, you tailor it to the patient. Weight loss is the only one that has actually been shown to actually reduce objective reflux parameters in all of those. All right, PPIs. I take a PPI and it's helping me, and then it doesn't work anymore. You've heard that from your patients, right? That tolerance issue that they're implying. There is no tolerance to PPIs. Tolerance is with H2 receptor antagonists. And in fact, when you look at long-term studies, this is a LOTUS trial, which was LOTUS 1 and then LOTUS 2, so to speak. Their 3-year and then their 5-year follow-up. What you notice here, this was a study that was comparing PPIs to surgery. If it works, it continues to work. Why do some of our patients say, you know, this PPI was working, now it stopped working. It's not anymore. So those are all questions that you got to ask, well, is this really reflux related? Could it be something? That PPI wasn't that it was working, it's just that it was that placebo response. Now the placebo response is wearing out and the patient's saying it's not working anymore. So be cautious with that. There are about 3 to 5% of patients that don't tolerate a PPI versus another, but that's a very low percentage. So PPIs, if given in the right condition, if it's reflux related, will work and it will continue to work. This is now the 5-year follow-up of that study. Again, it works and it continues to work. When you look at the dosing in that trial, you notice that most patients that were on once daily continue to do well on their once daily. All right, refractory symptoms. What could be the cause? You do, if you're all gastroenterologists and or surgeons, what is it that you do? You do diagnostic tests to determine if the patient's symptom that's persisting is from reflux or reflux-related causes or non-reflux related. If I'm on twice-a-day therapy, what is the likelihood that I have continued acid suppression if I still have symptoms? So, am I compliant? Did I change the dose of medication? Remember the abstract that I presented when they talked to the patients and they told them when and how to take it. 11% of patients, their symptoms improved. So it's not a huge percentage. So don't think somehow you're going to go from 100 of your patients that are not better on twice a day by telling them what to do, they're all going to be better. 11%. Is it Zollinger-Ellison? Again, clinical suspicion. Nocturnal acid breakthrough. This was big in the 90s. That's why we started giving H2 receptor antagonists at nights. We don't do that anymore. Tolerance and also nocturnal acid breakthrough is a gastric phenomena. It is not an esophageal phenomena. You all have nocturnal acid breakthrough in the stomach. You all make acid in your stomach. That doesn't mean you're refluxing and you have GERD. So a physiologic phenomenon in the stomach doesn't necessarily translate in the esophagus. Non-acid reflux, in the 90s, Joel Richter and I did all these studies on bile and bilirubin with Billy Tech about what's the role of non-acid reflux, or in that case, bile reflux. Then impedance pH monitoring came about. This told us more about non-acidic or weakly acidic as opposed to bile alone. Billy Tech only told us about bile. This tells us about non-acid. I'll go over this. What do you do with someone that's not better on twice a day? Endoscopy is normal. Impedance pH on therapy is slightly abnormal. So now two pieces of the puzzle you're questioning, and one piece of the puzzle is telling you, well, it's slightly abnormal. What do you do? And there are not a whole lot of outcome studies other than the VA cooperative that I shared with you this morning that says maybe if the acidity is abnormal, you could potentially refer to surgery, but we can talk about what subgroup. Not reflux related is going to be where I lean toward for most of my patients. It's not going to be reflux disease if endoscopy normal, if not a large hernia, if not regurgitation. Most of these patients are going to have non-reflux related symptoms. All right, compliance, we talked about this. Talk to your patients about taking the medicine the way they're supposed to. And then endoscopy. So you have a patient with twice daily therapy, not better. You do endoscopy, what's the likelihood, the pretest probability you're going to find esophagitis on therapy? That's right, not very high. It is possible. Remember the first study, the abstract I showed you, enrolled 1,000 patients, 300 had abnormal acid, so 30%, and or esophagitis. It's not zero, but the likelihood is low. Barrett's, what's the likelihood you'll find Barrett's? Caucasian male regurgitation hernia, that's associated with Barrett's. If you don't see it, you're not going to have it. So endoscopy, you're not doing endoscopy to find something in this group. You're doing endoscopy because you want to rule out reflux. So there's rule in and rule out. You're really ruling things out. You're not going to find that in a patient with burping or heartburn, less likely. That's a dysphagia. You're not going to find that. In guidelines, it says if someone is refractory, you should biopsy. If someone's refractory and I go in and everything looks normal visually, and I'm an esophagus guy, all I see is esophagus, it doesn't look like this. It looks completely normal. I'll biopsy it, but 10 out of 10, that's going to be normal. So again, use your clinical suspicion. If I see this, I don't need biopsy to tell me what that is, right? A patient has dysphagia, food impaction. I'll biopsy it because that's what the guidelines tell you to do. But that you already have the diagnosis, your pretest was high. But this is what you're going to see in most of your patients when you scope them, normal. So, normal endoscopy, lack of response to BID PPI therapy. That's actually helpful. You're leaning now more and more away from reflux as the possible cause. You could biopsy the esophagus. You've read about dilated intercellular space. Well, if you have reflux, it may look normal, but you could find alteration in the lining if you did that. Well, yeah, you could, but where do you biopsy? Do you biopsy 3 o'clock, 2 o'clock? How far up? There's variability on this. There's cost associated with this. You're not going to be able to do it in clinical practice. You shouldn't, because you're becoming more sensitive at the cost of specificity. In other words, you might find this, but in a patient on failed BID dosing, what are you going to do if it's abnormal? So put it in clinical perspective. EOE I already showed you. And, okay, this patient had come to me with refractory GERD as the diagnosis. No, it's not a colonoscopy, right? It looks like a colonoscopy. So dilated esophagus. Now, why is it that we miss echolalia? This is echolalia, right? So food in the esophagus, dilated esophagus. The number one symptom most of patients with echolalia come to me as is refractory GERD. Not what we write, dysphagia to solids, liquid. Dr. Vaezi, I have dysphagia to solids and liquids. I regurgitate when I lay down. That's not what they say. What do you have? I got heartburn. I have things coming up, and I've taken PPI. It helps a little. That's where we get confused, right? So, but this is not going to confuse us. You see this, it can't be anything else. It could be that you got wide open GE junction, you got bad gastroparesis, you got regurgitation, but when you get to the GE junction, it's puckered and it's hard to get through. This is going to be nothing but echolalia or pseudo-echolalia. That's your manometry showing that's echolalia. All right. Burping, all right, mealtime air swallow, huge overlap of the data on PPI responders or PPI refractory. Sure, some patients swallow a lot of air, they burp a lot. That's not by definition reflux necessarily. I told you don't do pH, so there's controversy about should I do my pH monitoring on or off therapy. You should never do pH monitoring on therapy, especially BID dosing, because remember what I said, 99% of patients will have normal findings. If your pretest says 99% it's normal, why are you doing the test, right? So it's not going to help you to just do pH testing. If your clinical suspicion is high, this patient's regurgitating, this could be reflux, take them off therapy and do pH testing off therapy to see if they have reflux. Is it mild, moderate, severe? And on therapy, it doesn't help you, especially in atypical, but in typical patients, esophageal, it's the same. 93% is going to be normal. All right. We do pH testing. You have the pH. What do you tell your patients? How many of you do pH monitoring? Just raise your hand. All right, quite a few. You tell your patients, push the button when you have symptoms. These are pushing the buttons, heartburn, chest pain. You correlate the two, and we have different metrics. Symptom index, symptom sensitivity index, or symptom association probability. The one that's more popular is the symptom association probability, or SAP, right? So what is SAP? You divide, this is a 48-hour monitoring, you could divide 24 or 48 into 2-minute windows. 2-minute windows. Is there reflux? Yes, no. Is there symptom when they push the button? Yes, no. If the answer is reflux, yes, symptom, yes, it goes in this box. You just count the number of those, let's say 20. And then, is there reflux? Yes, symptom, no, and all the possible combinations. So, then you do a chi-square test. Where did this come from? This came from, again, in the 80s when we were doing pH monitoring in non-cardiac chest pains. In non-cardiac chest pain, SI was the one people were using. They said, well, SI is not scientific. Chi-square is a better statistical method than just number of symptoms that were associated over the whole number, so this may be a better test. That's it. That's how this became so popular. No validation of this. What is the number one presumption when we suggest that SI or SAP is good? It presumes that when you tell the patient to push the button, they're going to do it when they have the symptom, right? That's the number one presumption of the test. Well, does that happen? We can't do this test on heartburn because you can't monitor heartburn, right? It's a symptom. There's nothing that can monitor it. We monitored cough, chronic cough patients. We put microphone in their necks and chests, and we told them to push and they had impedance pH monitoring. We told them to push the button when they actually coughed. But what we didn't tell them, patient was blinded, that we're going to actually listen every minute, every second. When they cough, we're going to see if they push the button, right? That's the only way to know if they push the button or not. Do you think they actually pushed the button when they coughed? Huh. So if you say, I just coughed, I give them a minute to push the button. That's 1 minute. What percentage of patients did not push the button within 1 minute of their cough? 90%. That's a bit stringent. Let's give them 2 minutes. They were in the bathroom, they forgot, whatever. 2 minutes. 80% did not. Give them 5 minutes. 70% did not. The point is, when I present this data, people go, well, it's not heartburn. This isn't about cough versus heartburn. This is about patient behavior. It's about the fact that patients will not do what you tell them. You know that. They won't do it exactly when it happens, and you know that. But somehow, we publish on SAP, and I'm going to be very critical on Rome criteria, in a minute about this hypersensitivity syndrome because of that. When you look at the chi-square, the 2x2 in patients, look, 95% of data that decides whether you're SAP positive or negative is all in no symptom, no reflux. This box, which is S plus R plus, is the smallest. there's only a 0.48% difference that flips you from SAP positivity to SAP negativity. Then we use that as clinical way of diagnosing, or remember the VA cooperative study I showed you? They're sending patients to surgery based on SAP positivity. Please don't because of this. This is more science, that's more voodoo. I would not do it because it makes no sense. The whole premise of symptom indices makes no sense, so be cautious. This is Rome 4. Rome 4 says there's erosive esophagitis. If you see it, great. There's non-erosive. Well, that means the patient has reflux by pH testing or impedance pH testing, but they have no erosion. So you have objective way of deciding whether someone has symptom. Then there's this voodoo, reflux hypersensitivity. I don't know what that is. This is how it's defined. It's defined by the patient's SAP being positive, but they don't have reflux by traditional reflux parameter. But more importantly, what do we do for this group of patients? I don't care what one calls it. If one sends this patient to surgery, that's wrong. But actually, what we do currently, if you look at all the algorithm, this group gets treated exactly the same as our functional group. Patients don't get better on PPIs, then you treat them with neuromodulators. Well, why isn't that the same as functional? I know why, because many of our experts know that there is a group of patients, a subgroup, that when you drip acid in the esophagus, they feel it more than others. That concept is inside of all of our minds, which leads to this diagnosis, but we shouldn't use SAP to make this diagnosis. So be careful. So when I have a pH monitoring report that spits out positive, I don't even care. If it says negative, I don't care. I'm looking at parameters and I'm looking at whether patients got better, how much, which symptom got better, which symptom didn't, all the things that you currently use in your clinical practice. I don't know what to do with that. All right. Now, to be a little more provocative, as if that wasn't, let's talk about functional heartburn. What do? You have heartburn, normal endoscopy, you didn't get better on PPI trial, and everything else is okay, no response, functional heartburn. Okay. Functional chest pain, normal endoscopy, manometry is normal, PPI trial normal, then that's functional chest pain. You're going to see a pattern to this. Dysphagia, normal endoscopy, manometry, biopsies normal, barium swallow normal, PPI trial negative, functional dysphagia. Globus, normal endoscopy, manometry, barium swallow, PPI trial negative, that's globus. Well, why wouldn't, this is now me calling it Rome 5 criteria, there is no such thing, I'm sort of pushing this, hopefully they'll invite me to Rome and I can push this further, I just want to go to Rome. Functional extraesophageal syndrome, cough, throat clearing, these are really irritable larynx syndrome. We have all of those patients. They have irritation. So that's what this is, right? We don't need to create anything. This is functional. Now, hypersensitive, how are we going to treat it? Guess what? We do all the other parameters. So, by the way, these are my criteria. No malignancy, pulmonary disease ruled out, sinus evaluation. If all of this sounds familiar, it's because that's what the world all of us live in. Laryngeal evaluation, either been called GERD or LPR, or no lesions. GERD, treated, no response. Zenker's fistula, negative. This is functional, okay? Now, these are my criteria. Vaezi 1 criteria. Must include all of the following. Bothersome cough, throat clearing, or sore burning throat at least several times a week. You have those patients. Absence of evidence that GERD is the cause. They've been treated. You've tested them. Absence of sinus, endocrine, pulmonary, laryngeal disorders. And criteria fulfilled, I'm just being funny here, for 3 months, at least 6 months. Well, all of this fits into all the patients we see. All right. Efficacy of PPIs best in when you have your objective parameters that are abnormal. Esophagitis, objectively abnormal, that patient population will respond better to PPIs. You know that. If I do pH testing and it's 15, 20% abnormal off therapy, then they're going to respond to PPIs better. So esophagitis, heartburn relief, regurgitation, somewhat. Chest pain, chronic cough, they don't do well with PPIs because most likely it's not reflux related, it's that functional symptomatology. So, what do we use to send patients to surgery? So Dr. Vaezi, great, but what do I do with my patient? First, you rule out reflux. You tell the patient this is not reflux related. But more importantly, who do you send to surgery? Well, I would send to surgery patients that have heartburn regurgitation. They tend to do better with surgery than those with extraesophageal syndrome. Be cautious sending someone with chronic cough that has not responded to PPI therapy. Their cough hasn't. Let's say I have cough and heartburn. My heartburn's better, my cough isn't. When I go to surgery, my heartburn will be better, but not my cough. That's what you got to tell your patient, because that's what the problem lies. Is heartburn regurgitation a better marker than extraesophageal? Response to acid suppressive therapy for both of those groups much better than not response. These are response to surgical fundoplication. So I have heartburn, I'm on a PPI, I'm better, I don't want to take PPIs forever. Fine. Fundoplication will help you, but you got to talk to them about all the things that come with fundoplication, right? The bloating, the burping, sometimes they get gastroparesis because of the vagal damage, right? They can have issues with not swallowing for a while, so discuss that with them, but they will do well. All right. What about sending patients with extraesophageal reflux to surgery? We did this when I was in Cleveland, twice daily therapy. They didn't get better. Non-responders, we sent some to surgery. Some continued on their therapy. This gets to the point that if they're not better with PPIs, they're not going to get better. This is the response to surgery. If they hadn't responded, they're not going to respond to surgery. So regurgitation is the only exception here. If you've ruled out echolalia, you've ruled out gastroparesis and rumination syndrome, those three most important, and someone says, I have heartburn and regurgitation, when I lay down stuff comes up, remember, rule out echolalia and all these, then that patient, especially if they have a moderate to large hiatal hernia, they're telling you they have volume regurgitation. It's a volume phenomenon. PPIs do not do anything to the volume. They're just reducing acidity. So in that sense, that group may do better. So getting back to the slide that I shared with you about why patients have refractory symptoms, I don't think it's because they're continuing to have acid reflux. It's a small percentage of patients. I don't think it's non-acid reflux if there's no regurgitation as a symptom. I think it's mostly because they have non-reflux findings. However, do your test, prove it isn't reflux. You're looking for negativity, not positivity. A positive test that doesn't fit, ignore in clinical practice. So, what's the algorithm then for your patient that you suspect has reflux? If alarm symptoms, you're going to do endoscopy. You treat them once daily therapy for the typical symptoms for 1 to 2 months, no longer. Twice daily for extraesophageal for 1 to 2 months, no more. ENT literature says 4 to 6 months. That's not true anymore because they're looking for resolution of laryngeal findings, vocal cord granulomas and what have you. That's different, not the typical LPR patients. In 1 to 2 months, your patients should tell you the following: Doc, I'm so much better, or I think I'm improving. That gives you an idea this could be reflux related. You continue another 1 to 2 months, but then you taper. If they're not better at all, I'm taking it, no change. So if symptoms improve, you titrate. If they're persisting, change PPI. Some say, oh, let's change PPI from this to that. I don't do that necessarily because PPIs work pretty well unless someone has side effects with a given PPI. That's why the dashed arrow. Impedance pH on therapy. Who do you do impedance on therapy? If you look at ACG guidelines on do you do test on or off therapy, if it's off therapy, you do wireless pH monitoring. If it's on therapy, you do impedance pH on therapy. And the ACG guideline says if your level of suspicion is high that they have reflux at baseline, pretest probability for reflux is high at baseline, then you do impedance on therapy. But what they don't clarify is what is the pretest probability of high and low mean, right? So we've clarified that now. There's a manuscript that's in review. Hopefully it will come out. If you have a patient with asthma and heartburn, that's a high pretest probability. That patient, if you do pH monitoring, 80+% of the time will be abnormal. You're not interested in that. You're interested in knowing if they're continuing to be symptomatic. If it's cough only, hoarseness only, laryngeal symptom only, no heartburn, Do it off therapy because you want to know if it's normal off so you can look for something else. All right. I don't know what to do with a positive impedance when everything else is normal. I would never send that patient to surgery with that test alone. And then if there's bloating, early satiety, you're looking for gastroparesis, you're trying to rule out motility disorders. And then at the end of the day, if you've done all of that, everything is normal, you're really leaning into functional, right? You notice what I didn't include is the hypersensitivity because I treat them the same. I treat them as functional. So you're looking for neuromodulatory agents. In cough, I can tell you there are many studies now with using gabapentin as treatment for chronic cough, again, that irritable larynx. And again, most of them are not placebo-controlled. There's, I think, one, maybe two. But there's some benefit if you're going to use it. Again, off-label. I start at 300 milligrams. I don't use any more unless they get improvement. If not, I stop it after 2 months. And then same thing with other neuromodulatory agents. I think at the end of the day, you're left with reassurance and reducing anxiety. You got to ask the question, why are my patients letting me do all these tests on them? Because they're worried. They have a symptom you haven't improved. So educate them about what this could be, look at other factors, and hopefully that'll reduce anxiety. Thank you so much. We have a Q&A.
Thank you, Michael. That was a master's level class in GERD and non-GERD. And we have a question.
I've appreciated your editorials over the years, and I love your concept of using your clinical judgment and insight when you talk to the patient, because I think we are probably more right than wrong when we make an assessment in these patients. And your algorithm is great, and I think most of us probably follow it. Why do you even have the box for pH monitoring? I have the conversation with patients that simply says, if you haven't responded to a double-dose PPI in a few months, your chance of having reflux as a source of the symptom that the ear, nose, and throat doctor sent you here for is exceptionally low. And what if I proved you do have reflux? Would you actually agree to an anti-reflux operation after a whole bunch of tests? And everybody says, of course I wouldn't have surgery. So I've dropped off significantly referrals for pH monitoring. I'm wondering what your thought is.
No, your point is valid. So you have to really, I don't like putting all patients into the same box. Your point was 100% valid for patients with chronic cough only, patients with hoarseness and sore throat. Patients with asthma, it's a different population. Patients with IPF is a different population. Because of that negative intrathoracic pressure, they're by default going to have reflux. And if your endoscopy is normal, then I wouldn't do pH testing because the likelihood is that the reflux, whatever that might be, is low. Low meaning between 5 and 10%. So I sort of tailor it to what the patient's presenting with instead of putting them all into one box. The reason I leave the pH monitoring, especially in the low probability group, which is the cough hoarseness, is because the patient sometimes doesn't believe what you tell them. They would believe an objective test that's in front of them more. So I use that negative finding on a test to prove the concept that you nicely outlined. I agree with you. So if it's a patient that says, you know what, doc, yeah, if you tell me it's not reflux, that's fine with me. And if you get a sense they really want something else, or if the referring wants something else, then that's the main reason I do it, to just show them it isn't reflux. But your point is 100% valid. The pH off therapy in a group that is not responded, doesn't have regurgitation, has normal endoscopy, I don't know the value of it clinically for you guys. We do it for research mainly.
Just to follow up on that, so I think the most provocative and potentially dangerous study is the VA cooperative study. And I wondered, and I know we have yet to see a manuscript, but the pH monitoring there was done on twice daily PPI. And so there is that tiny subgroup, at least half of the patients who were actually enrolled had an abnormal pH. So it does happen in that small group, and you kind of indicated you thought maybe that might be a group that might benefit. Yeah. But what do you, look into the crystal ball here.
Yeah,
where is that study going to come out?
I would love to see the details. In fact, I got up to ask a question, but you would think that important a study, presidential, DDW, they would have Q&A session. They didn't have Q&A session. I got up to really be critical of that. So physiologically, so that you guys know what's the pretest likelihood of all of this stuff. take a patient with Barrett's esophagus. If I tell you someone has Barrett's, clearly they have reflux, right? By definition, they have Barrett's, they have reflux. If you do pH testing in the esophagus in that group on therapy, this is now your spectrum of reflux that's on the more severe side of reflux. On once daily therapy, 40% continue to reflux. On twice daily, 80% are controlled. So BID dosing, 20% still have reflux. When I do twice BID, like quadruple dosing, then I'm controlled everything. So there's still a subpopulation of patients that will reflux, but in your more average patient that has not responded to any therapy symptomatically, that likelihood is exceedingly low. Again, no more than 10%.
So you think are on PPI BID, how many actually are on BID? Do you have them bring the bottle in? Do you do blood levels? I just wonder.
Yeah, that's the compliance. You're absolutely right. When you talk to the patients, that's why I never ask my patients, this is an important point you're bringing out, that gets to the compliance. I never ask any of my patients, did you take the medicine? What do you think the answer is going to be? Of course. What I ask them is, what happens when you didn't take the medicine? That's more important clinically, because if they tell you, oh no, I can't not take it, that means they tried not taking it, and their symptoms came back. That's an important clinical pearl, right? Because if they already said, I can't not take it, or the answer would be nothing. That's an important clinical observation, because less likely it's reflux related.
One more question.
Yeah, I'm faced with an epidemic of ENT referrals for LPR.
Sounds like you're the only one.
Yeah. What percentage of patients with chronic cough have reflux who have zero acid reflux symptoms?
Yeah, that's a great question. This is where my clinical suspicion was wrong. So we did a study where you have chronic cough only, you have chronic cough that also has heartburn, and then you have heartburn as a predominant symptom. 3 separate groups. Which group do you think would have more reflux if you do pH testing off therapy? You would think maybe the heartburn group, followed by the one cough plus heartburn, followed by cough only. So if you only use normal, abnormal of the pH cutoff. So a sidebar, I'll give you the answer in a minute. I don't use cutoff of normal, abnormal. That's a dichotomous way, right? Somehow we have to have what's normal, what's abnormal. In this group of patients, it's a spectrum. I use it, do you have a lot of reflux or not? I'm using it more moderate to severe. I'm not interested in someone having 6%, 7%, 8% if they haven't gotten better on BID dosing. The answer is of those 3 groups, they were the same. So pH testing off therapy, 80% of patients have mild reflux at baseline. I'm not interested in a chronic cough patient with mild reflux at baseline. I'm interested in a hiatal hernia. I'm interested in moderate to severe reflux at baseline. The answer is you can't use it alone as a criteria.
Thank you I think we're going to have to take the last question offline, maybe.
Yeah, I was just curious if you ever test for H. pylori, just because I was one of those patients who asked my primary care to test me, and I was on a course of antibiotics and I got cured.
That's great. I don't, when I do endoscopy, if I suspect there's, there's gastritis, I will biopsy, especially in specific population of patients, but not for these symptoms like cough or what have you. Good, thank you.
Thank you very much. Okay, everybody take a deep breath, because this is probably the most complicated topic we're going to have today, the highest quality of abstracts. So we had to get almost a royal flush of IB